Thank you for inviting me. I'm Dr. Judith Salmon Kaur, Director of Native American Programs here at Mayo Clinic. And I have information to share with you that hopefully will enlighten many of you about what the implications are of the Affordable Care Act on American Indian health. Dr. Don Warne and I have tag-teamed this at different presentations, including the Association of American Indian Physicians in the past year. And this is still a work in progress as far as the Affordable Care Act. As most of you know, many aspects of the act are still rolling out, and there are still legal challenges to some aspects of implementation. But I'm going to tell you what we see as the potential for this to dramatically change and improve access to care for Native populations in this country. The Spirit of Eagles program is a national community networks program that focuses on American Indian and Alaska Native health, particularly as it relates to cancer. So the Spirit of Eagles has been involved in this process of trying to understand what access to care would look like, particularly cancer care, but many aspects of prevention and specialty care are affected by the Affordable Care Act, ACA Obamacare. And so in order to educate our communities and to work with leadership nationally, such as the National Indian Health Board and the Association of American Indian Physicians and our own colleagues here at Mayo Clinic, we felt we needed to stay on top of what's happening with the Affordable Care Act. So here are some of the major changes that are occurring because of the Obamacare Affordable Care Act. Many of you may not know, but the Indian Health Care Improvement Act for many years languished and was not refunded and not reenacted because of a lapse of leadership on the congressional level. Every year there is a budget that is presented to Congress for Indian health care, but it did not include the features that the Indian Health Care Improvement Act had advocated for a number of years. So this became a particularly advantageous time for Indian health care to partner with other people interested in the Affordable Care Act to make sure that it did not get left out at this propitious time. So it does allow for federally recognized tribal members to be exempt from the individual mandate. The individual mandate has been one of the contentious aspects of the law, as you might recognize. So why were Indians exempted? Well, the federal government has a treaty obligation to provide health care for Native people. In fact, I used to say that Natives were the only ones that were guaranteed health care in this country, and then someone reminded me that prisoners also are guaranteed. There is extended enrollment for American Indians and Alaska Natives also. So for example, the enrollment time frame for this particular year started in November 15th of 2014 and goes to February 15th of 2015. So you'll see a lot of ads on TV about how you've got to get in there, you've got to register before the enrollment period closes. But for Natives, there is a monthly opportunity of several days that are published when Natives can enroll. So every month there is a new opportunity for people who had not enrolled to enroll. And that's partly because a lot of our populations are very rural. It's harder for them to get places. They have been trying to set up navigators for the Affordable Care Act to work with tribal communities, but all of that takes extra time than what it does, say, in a different environment. Very importantly, the Affordable Care Act recovers costs from third parties to tribal facilities. So a lot of the care that tribal facilities provide to, say, Medicare eligible patients never gets paid by Medicare if they don't invoice for it. So there are particular fiscal incentives for tribes to start billing essentially for services that they provide that could be provided by other payers, including Medicaid and Medicare and children's health insurance funds. It improves collection from those third-party payers because of that. So the Indian Health Service is not insurance. A lot of people misunderstand that, and even Native people are likely to say when asked, what's your insurance, and they'll say Indian Health. But it is in fact not an insurance policy. It is not portable where you can go to an emergency room whenever you want, or to a clinic and say, here's my insurance card. Indian Health Service is very restricted, very based on the tribal enrollment place for the individual to receive that care. And that leads to a lot of delays in care if patients have to be going through a referral process. For example, I saw a cancer patient as recently as yesterday who had to wait 4 months to get a prescription filled. And that was untenable. And it definitely leads to disparities in outcome for major diseases such as cancer. So the Indian Health Service is the principal federal health care provider and health advocate for Indian people, but it was only set up initially to take care of emergent kind of situations and infectious diseases. It was never set up to take care of chronic care. And of course, in our country today, whether you're talking, the average Caucasian middle-class person, or you're talking a Native American, chronic diseases are the major healthcare need, with the advent of diabetes and heart disease and cancer. And they all came to Indian country as well, just in a later time frame. So the goal of the Indian Health Service is supposed to assure comprehensive, culturally acceptable, personal and public health services that can be available and accessible to all American Indian and Alaska Native people. Unfortunately, because of underfunding and understaffing in so many areas of the country, that really does not fulfill that promise to Native people that was made in treaties. And the tribes do have a government-to-government relationship, and so the tribes have the right to negotiate with the federal government, and they do that every year. And there has actually been, under the Obama administration, an annual White House consensus with meeting with tribal leaders. But in that, healthcare is not the only agenda item. It can be environmental health. It can be many other things. So health is not the only thing that's government to government. The Affordable Care Act, if you were to read the over 1,000 pages, and I don't think too many people have, there may be a few congressional staffers who can claim that, but most of us have not, has 11 different titles, the last of which was the Indian Healthcare Improvement Act that got put in just in the nick of time. Many people are aware of the Medicaid expansion and even the Children's Health Insurance Program. But again, there's a lot of misinformation about that. And then there are all these other kinds of initiatives that are involved in the Affordable Care Act. And some of that relates to things like prevention and wellness, and we'll talk a little bit about how that can affect cancer screening. Dawn?
Quick question for number 11. Does that also include Alaska Native?
It does.
It does, so just the
Right.
name is not in there.
Correct.
Okay, thank you.
So the affordable and available coverage is what they call a three-legged stool. It's insurance market reform, which is the marketplace piece that you keep hearing about in the news. It's individual mandate and responsibility, which doesn't apply to Native people, and the premium and cost-sharing subsidies. So the state insurance exchanges are a part of that marketplace. Employer responsibility this year and next year will be kicking in for employers that have more than 50 employees, and that's also somewhat contentious as far as then will those small businesses not hire more people. But again, for American Indians and Alaska Natives, the individual mandate responsibility is not there. Medicaid and children's health insurance, the eligibility has changed, and so it's been broadly expanded. I heard one calculation that a family of 4 with income of $100,000 could still get a subsidy under the current calculations. And so likely a very high majority of Native people would also qualify for Medicaid under the expansion rules. And the sweetener is that the federal financing was going to be 90% for the first few years. And the caveat to that is that the states that expand then can't go backwards and can't say later, will you take this back and still fund 90%. And so how to pay for all that Medicaid expansion is a big issue and probably has a major impact in terms of access to care going forward. How they're going to solve that, nobody knows just yet. And uniform eligibility and enrollment standards for Medicaid and children's health insurance are also part of the act. But, you know, instead of focusing on some of the obscure financial and legalistic things, you know, some of the things that are very, very positive about the Indian Healthcare Improvement Act as part of Obamacare or the ACA is that it establishes community health representatives to be trained for urban Indian clinics. What's happened in the last couple of generations is that the majority of Native people actually live in urban areas now, but the resources did not follow. Whereas about 63% of natives live in urban areas like Minneapolis, Denver, LA, only 3% of the Indian healthcare budget goes to those urban clinics. And that many Indian people are therefore forced to go back to their home reservation and reclaim the right to health care by residing for a minimum of 6 months typically in most of those reservation areas. So it's very disruptive for families, very disruptive for people who have jobs that in order to claim their historic right to health care promised by the federal government, they have to go through enormous sacrifices to try to get that. So the community health representatives would be navigators and would be people that can do a lot of the education, much as they do on the reservations. And if patients do in fact sign up for Marketplace or Medicaid or CHIP, they would then have immediate access even in the urban areas and not have to go through all those hoops in order to get care. It also directs the Indian Health Service to establish comprehensive behavioral health prevention and treatment programs, an extremely important need. The highest suicide rates in the country are young Native people, for example. You know, the addiction problems and the lack of jobs on the reservations and the you know, child abuse issues are all things that tribes are grappling with, and we really need services that establish comprehensive behavioral health as well.
Hopefully another quick question. CHR, do they tend to be Native people who get trained to do this?
Yes, right. They live in the community. Most of them are Native, or it's at least Native preference. Okay. You know, if there just aren't people that are qualified or available, there are non-Natives who serve as CHRs. In Alaska, they're called CHAs, Community Health Aides, and they go through a special training program as well in Alaska, and many of them are the only caregiver out in the villages, you know, in very remote areas. So it's very important to have these people as real resources to the communities.
Judy, where are they getting trained right now?
So right now, they're not trained for the urban areas. They're trained by a CHR program that's run by the federal government in conjunction with the Indian Health Service.
On each of the tribal reservations?
In regions. So there are all these Indian Health Service regions, and so they hold regional training programs. So it also authorizes Indian Health Service and VA to share medical facilities and services. Extremely important because a very high percentage of our Native people, both men and women, are veterans. And so, for example, there may not be available colonoscopy sources available on the reservation, but if they can go to the local VA and get that resource, it will again overcome a lot of the delays in treatment. So the VA now has an agreement with the federal government for tribes to be able to access services from the VA that aren't available in their own community. And it also allows tribes to purchase health benefits coverage for Indian Health Service beneficiaries. So why is that important? Well, For example, cancer care, very expensive. If they could cover their patients for extraordinary care, such as cancer care, through policies with commercial insurance, it would cost them a lot less, probably, than having to wait and do contract health care services and have the delays to get patients into treatment. Because treatment for identified cancers has been a big problem and a very costly thing for tribes to undertake. It also authorizes hospice and assisted living and long-term and home community-based care that a lot of the general population has enjoyed for years, but has not been available to Native people. So Alaska, for example, years ago tried to get authorization to set up hospice care in the villages, and they couldn't meet the federal qualifications of what a hospice must do, the face-to-face meetings, you know, the 24-hour care. And so they were refused any availability to get a waiver to provide hospice care in the villages. And what they showed with a pilot project was that if they had that available, the majority of elders would choose to die at home, not in the ICU in Anchorage or in the cities. And so it would be a very cost-effective way and a very culturally appropriate way for people who are going to pass to be surrounded by family, their spiritual leaders, their native healers, etc. So we saw that need with the Spirit of Eagles program many years ago, and it is one of my areas of specialty as well. And we have trained a minimum of 25 teams across Indian country in palliative care and hospice, and that is ongoing, and Indian Health Service now recognizes that need and is collaborating with us again to try to look at various ways that we can make that training available to communities that want that. In 2013, the Navajo Nation hosted the training, and so that was the first time that a southwestern tribe offered to be a leader in terms of hospice and end-of-life care. Very important in terms of the cultural aspects of that as well. So for natives, there is no penalty for maintaining minimum essential coverage. So, you know, unlike you're hearing this year that people who didn't take a policy for minimal coverage could pay a tax that the IRS could impose on them. That does not apply to Native people because, again, of the trust responsibility of the federal government. And for cancer, mammograms are free, which, again, for many Native people, there are very few mammography units out in reservation communities, and many of them have had to travel a great distance to get that, and then the outlay for the tribes to send people in and get the mammograms has been extraordinary. So this would dramatically free up funds for the tribes to be able to do other primary-based care as opposed to cancer screening. And it also includes free colonoscopies for people who appropriately need to be screened. There's no cost sharing for Native people if they are less than 300% of the federal poverty level, and that would, you know, probably be the vast majority of Native people. No pre-existing condition denials for any of these policies. Children with terminal cancer can receive hospice care under the benefit, and the Indian Health Service tribal and urban payers would be payers of last resort for specialty care. And that's extremely important because what they do best is the primary care. If they could be really in a prevention mode as opposed to just a triage, life and limb as it's called in Indian Health Service, they would be able to do a better job of maternal and child care, diabetes prevention, cancer prevention, heart disease prevention. So what Dr. Warne and I have found is that for those tribes who've already bought into having the Affordable Care Act benefit their populations, some of them are building wellness centers, nice exercise facilities where all the diabetics can have an exercise program with a trained dietitian and exercise physiologist and so forth. What a dramatic change that could make on diabetes in many of these situations. And I do remember years ago when diabetes started to be so profound and so many Native people were being shipped off to dialysis centers that the initial thinking was, well, you know, we're spending all that money to send them to dialysis centers. Let's build the dialysis center on the reservation. And now it's the flip of that. With the investment in diabetes prevention, education, and standards of care, the emphasis is on preventing those end stage aspects of diabetes and making the diagnosis early when you can have the most impact on the patient and the family. So if you want to read a lot of detail, the National Indian Health Board has an excellent summary of the Indian health provisions on the website, and they actually have a policy subcommittee that meets bi-weekly to update on what's happening with the Affordable Care Act, how to implement a lot of these things. So they have been a real leader in this. They also received a major subcontract to set up the navigators for enrolling tribal members.
Do we have anyone at Mayo on that committee or the board?
No, it's the Indian Health Board is all Native tribal representation. So every tribe has a representative on the National Indian Health Board. And Spirit of Eagles has a regular presentation at their meetings, and we participate in their consumer conference every year as well.
And would that be every federally recognized tribe?
Federally recognized, which is a very important consideration, Dawn, because those that are not federally recognized and just state recognized would not have these same extra benefits from the Affordable Care Act. Okay, so Medicaid expansion, as you've heard, has been ongoing, and unfortunately most of the states with large American Indian populations have not expanded their Medicaid programs. So I'll show you the map of that. In blue are the ones that have been implementing, which includes Minnesota and North Dakota and Iowa close to us. Wisconsin has not, Florida has not, Texas has not, South Dakota, Montana, Wyoming, very large populations, Oklahoma. All of those native places are not expanding Medicaid. So the tribes will not have the benefit of trying to enroll in programs through those Medicaid expansions. Now some of those are rethinking things this year. I think Florida is thinking it over again. But again, we're certainly nowhere near 100%. There were 27 or 21 last time I heard that were not doing much. So the exchanges are an important aspect of this, as we said, part of the three-legged stool. The healthcare exchange is a marketplace, and so it's a person can go there and look for what plan meets their budget, meets their health care previous pattern, get different choices. Some have described it as being the Expedia of the healthcare industry. And some people have said that the act overall has benefited the insurance companies more than a lot of the patients who really need the health care. On the other hand, there are more people in the past year who've had health care because of these plans than existed before the act. Enrollment began really only slightly over a year ago, and coverage began a year ago. So, and it was a very bumpy ride, as we've all heard at the beginning. This year seems to be going a bit better with more IT support, that kind of thing. So Minnesota is a good example of a big change in the uninsured. Only 8.2% uninsured previously, and then after Obamacare, enrollment started, dropped down to 4.9% as of May last year. Of course, we won't know what the figures are for this year until probably May again. That's when they'll kind of update all those numbers. but it's a definite sign that at least for our state, and this is not Native in particular, that it has had a change. And I understand in a lot of states, there was a big article in the New York Times over the weekend about the pluses and minuses of states that expanded Medicaid, and they gave an example of Kentucky. And a lot of the small clinics are very grateful to have those clients have Medicaid, because in the past they were providing totally, unreimbursed care. And so for some of those smaller communities, makes a difference between a clinic surviving or not surviving, or attracting new doctors, or having new programs. So it's going to be interesting to see how that plays out for Native places also.
Judy, where do you go to find out what services are covered with the insurance?
So you have to go to the marketplace, you have to go to the individual policies, and for Medicaid and the CHIP programs, you have to go to the individual states to know. And I did ask that of our insurance here at Mayo, and they said for Medicaid expansion for the states that are around us, they will generally take patients who need specialty care that only we can provide. They're not going to take patients just for routine care, but cancer care, specialized surgeries, that kind of thing. Like 2 minutes, because he knows I have to run and get my purse. So the bad news for the initial calculations of how many Alaskan Natives and American Indians signed up in the marketplace at the beginning, there were only 13,000, out of almost 4 million eligible. So there's a lot of education still to happen. As I say, a few tribes have really figured it out and figured that they could save an awful lot of money by not having to do the contract health care dollars and delaying treatment and having patients be sicker or in the hospital more and paying those bills down the road. But the majority haven't really figured it out. The patient that I mentioned from yesterday, I asked her husband, who has been involved in tribal leadership. He really didn't know anything about how to enroll in the Affordable Care Act, and he's in a position of leadership. So, and I also hear that there are tribal leaders who get kind of backlash from individual tribal members who say, why do we have to sign up? We are supposed to be able to get care. And so it's that whole education process still has to be ongoing for people to understand, what the benefits might be.
So do we have an understanding what those barriers are to enrollment aside from process? Like, is there trust issues or?
There are the usual trust issues, the anti-federal government kind of, okay, they've said this before, but they never really did it kind of thing. And there is just the whole process of having somebody to navigate the system. These are people who never had to have an insurance before, who were always dependent on the tribal process of going before the health board and getting a referral and all of the, kind of barriers that entailed. But they knew that system. This new system, they don't know at all, and they don't trust it, so it's going to take some time for it to really make a big difference on most of the tribes.
And do we have someone at Mayo who can train us on how to train the leaders, train the trainers, in filling out the application?
Well, no, I think that by the time people come to us, they're supposed to have worked that out, right? So the National Indian Health Board and the Navigator program are the most important ones. So the fact that the Mayo pre-admission group are very familiar with it, and they say they're fine if it's Medicaid expansion, and if a doctor says this is something that we provide that's specialty care here at Mayo. If it's someone from North Carolina, they're probably not going to accept Medicaid from North Carolina, because they'll figure there are academic institutions there that can provide care closer to home. But, if you remember the family that had the Siamese twins from North Dakota a few years ago, the enormous team they put together to take care of such a unique situation that only an institution like Mayo could do. So you know, we're trying to provide information to tribes and individuals of how the law increases access to affordable care. The cancer screenings, the vaccinations, the blood pressure screening, cholesterol, tobacco cessation counseling, and interventions, very important and part of our program because this is a population that still has very high rates of smoking. And we are at a point now where tribal leaders are recognizing that the non-sacred use of tobacco is a dramatic negative for the health of the people and are starting to address that problem. But the resources for tobacco cessation counseling on most reservations is very poor. Birth control, we've heard the issues around that, depression screening, and for a full list, you'd have to go to healthcare.gov and wind your way through the website, I guess. So, the preventive services are ones that we're very much in favor of, the mammograms, the colonoscopies. Of course, being the home of the new Cologuard, we're hoping that fewer people are going to need colonoscopies and that something like a rollout of a good plan for how to screen high-risk populations like the Alaska Natives might dramatically reduce that process and would be very culturally acceptable as well. The discount on medications for the general population, the prescription drug donut hole has been somewhat closed, but most people would say that there's up to a $600 per person savings and that the donut hole altogether is going to be closed by 2020, so we'll see if that really happens. The price of drugs keeps going up, especially cancer drugs, I must say. So the exchanges, they're federally facilitated exchanges where states have decided not to. There are state-operated exchanges, and then there are state and federal partnerships, and the recent appeals court decisions are, you know, not clear about where that's going to settle out, and the Supreme Court is going to have to decide whether the states that did not set up exchanges, is that going to pull down a significant aspect of the Affordable Care Act. That does it mean that the federal government cannot go in and set up those exchanges? And that's a major legal argument right now. So I always thought this was kind of interesting, how the bill becomes a law. Well, they bypassed all of this in putting out the Affordable Care Act because it never really got introduced in the usual way. It didn't get amended in committees. There weren't second readings. It just kind of came as one lump sum. But most bills go through this process of they add bells and whistles, they take things away, and then it, you know, gets marked up and then it goes for a vote. And then it gets enacted with some pieces clearly missing, and then the funding is not always there because it is the House of Representatives that has to do all of the fiscal bills that surround any federal things. And then the state agencies that are supposed to implement it oftentimes are somewhat broken themselves, understaffed, underfunded, etc. And here's what the media reports about how this, you know, new program should work. And the middle one, I think that's still quite true, the Affordable Care Act. This is how the public understands it. It is a blank screen. And from our point of view in the healthcare field, if we could only get to what's actually needed, if we could do the basics, if we could really just do the basics, we would be so much further ahead. So are we moving forward? Well, you know, it's enrollment time again, so we hope that as people understand and as they put aside any of the kind of issues of, is this really going to be a permanent act or is this going to disappear? I think right now anybody who has the opportunity and otherwise would not be able to have affordable health care coverage, including many of our tribal people, we want them to take advantage of the law as it exists right now.
So what's the best way if we have a member of the community that comes to us and says, you know, I'm in my home clinic and I have these health concerns and they're not being met. I want to come to Mayo.
Mm-hmm.
What's the best route for them to follow?
Okay, so the best route is for them to sign up for like the Medicaid expansion. They have to prove tribal enrollment in order to do that. They don't need the tribe's permission to do that. You know, if they are having a hassle of getting through the contract healthcare services, they've now changed the name of it. I have to think, I wrote it down with Dr. Warne. They've changed the initials now. It's not, it's not Contract Health Services, CHS. It's a new jargon to go with it. But they could bypass a lot of that hassle, because if it is something that Mayo provides that isn't available to them, you know, without a long delay in treatment, then they could just come and present themselves and ask for pre-admission authorization.
Are there specific people at pre-admission that they can talk to help them?
Yeah, the patient affairs office and the you know, I don't know about the cultural navigation there, but they're very skilled at understanding what the implications are of patients coming in through the Medicaid expansion, and you know, what I call Miss Mayo manners. They'll be polite and they will try to help someone understand what the situation is as far as providing documentation. Well, thank you for your time, and I appreciate it, and this will be an ongoing conversation. Thank you, one and all, my devoted audience.
Thank you.